respond to your commands, and then again he will go to sleep. That is stupor. And coma is patient remains unarousable and unresponsive despite of repeated stimuli. There are a few other definitions that you also should know. So what is vegetative state? Second is akinetic mutism. And third is locked-in syndrome. So vegetative state means whenever patient recovers from severe large brain injury, massive brain injury, okay, or sometimes he may improve with the large stroke, in which condition for subacute to chronic time or period of time, more than months or years, patient would remain conscious. He would be wakeful, but he would not behave as a normal adult. He will not be able to think, judge, respond, perform executive tasks. Okay, he won't have any bowel or bladder continence. Okay, he will behave as if he is an infant. That is known as vegetative state. Patient is not effective in society. That's what we can say. He will be dependent for all activities on his family members. Okay. Akinetic mutism. It refers to the fully awake patient who is able to form some impression and think, but he will not move his body parts and he will not speak. Locked-in syndrome. Okay. When there is injury to the brainstem above the pons, what happens? Patient would remain conscious because reticular activating system would not be damaged. But there would be quadruparesis. Quadru means 4. So there will be paralysis of all 4 limbs. So patient would not be able to move his body. There will be paralysis of lower cranial nerves. So he will not be able to speak, swallow, talk. Okay. But upper cranial nerves would be okay. So vertical eye movements would remain normal. Okay. This is the worst situation in neurology, where patient would be fully conscious. He would feel pain. He would be listening whatever is going on. He would have some opinion, but he would not be able to talk or speak. Okay. The only way we can know that whether patient is understanding or not. So whenever you ask any question, patient will move eyes vertically. He will just blink the eyes. That's how you can understand that patient is conscious. Okay. That is known as locked-in syndrome. Now, there are structural causes of coma. Okay, large hemorrhage, large tumor, infection. Okay, but there are few causes where brain would be normal, but because of some other causes, secondary causes, there would be coma. And once you remove those causes, patient would regain consciousness. So metabolic, they are known as metabolic coma, which is usually reversible, where signs would be bilateral. So what are the causes of metabolic coma? So hypoxia, hypoglycemia, hypo or hypernatremia, dehydration, hyperglycemia, high temperature or very low temperature, hypothermia and hyperthermia, thiamine deficiency, which can cause Wernicke's encephalopathy, encephalitis, meningitis, microvascular emboli, and organophosphorus poisoning and other poisoning, hepatic renal toxicity, and subarachnoid bleed. Okay, this all may lead to coma, and if you treat the cause, patient would regain consciousness. Now, how do we approach to coma? So whenever we receive any patient who is not conscious, who is not aware of self and surrounding in the trauma, okay, first we will try to stabilize the patient. That is basic life support and advanced life support, because patient should not die, no, by the way. And before investigating anything, we should stabilize the patient. Okay, so first we will try to maintain airway, breathing, circulation. If needed, intubation, taking IV line. Okay. We will immediately do random blood sugar by glucometer. And if it is hypoglycemia, first we will give thiamine, followed by sugar. Okay. Always take care. Whenever you assess any patient who has history of road traffic accident and now patient is comatose, then you should never move his neck. Okay. He might have cervical spine injury. If you move his neck, it will lead to compression of the brainstem and ultimately permanent damage. Patient would become quadripartic, and there would be suppression of the respiratory center. And the prognosis and recovery would be very bad. Okay, patient would not be able to improve if you not manage properly. If you not manage the spine properly, you have to stabilize and then only you have to move. What should be what attention we should take? So assessment of the patient, we need to see for severity of coma, and we need to do diagnosis. We have to take history from relatives, witness, paramedics, ambulance persons, particularly about how was the coma started. How did the coma started? Whether it was sudden onset or whether it was rapidly progressive or it was slowly progressive. Okay. We should check the patient as per the following headings: proper history, assessment of the consciousness or arousal, how patient gets awake, how pupils react, how patient's eye movement is there, corneal reflex, conjunctival reflex, how is the breathing of the patient, what are the motor patterns and decubitus in the bed, and how are the reflexes. So in history, as we discussed, rapidity with which neurological symptoms have appeared will help you. Okay. If sudden onset, then it can be stroke or other hemorrhage or vascular pathology. If there is history of seizures, then it can be post-ictal coma. Okay. Other indication of sudden coma would be hypoglycemia, which is treatable. When it is progressive, it can be intracranial space occupying lesions like tumor. What were the antecedent symptoms? Antecedents means when coma started. Before that, what are the symptoms that patient had? So whether patient was confused, whether there was some history of weakness, whether there was history of fever, seizures, or giddiness, or double vision and vomiting. This all may suggest infection, intracranial infection. History of medications like cocaine, amphetamine, okay, cannabis, dhatura, then it may indicate that these are the culprit drugs which would have led to metabolic coma. Or whether any history of alcohol addiction, because alcohol over intake and alcohol withdrawal both can cause coma. Any history of liver disease, cirrhosis, which may lead to hepatic coma, kidney disease, nephrotic syndrome or nephritic syndrome, which may lead to uremic coma, lung involvement, which may lead to CO2 retention and CO2 narcosis, or heart failure and other illness. This is how we take history. Now we go for examination. So in general examination, if pulse is low, less than 60 per minute, bradycardia, then you should suspect hypothyroidism related coma, myxedema coma, or elevated intracranial pressure. Okay, it's a sign of raised ICP. Opiate toxicity. When the pulse is having tachycardia, more than 100, then patient can have infection or hyperthyroidism. If blood pressure is high, then elevated blood pressure may have led to coma, which is known as hypertensive encephalopathy. And if the blood pressure is low, then it can be because of alcohol toxicity, myocardial infarction, or Addisonian crisis. Okay. If patient has fever, then you should suspect septicemia, meningitis, encephalitis, heat stroke, coma because of exposure to excessive high temperature for long time, or anticholinergic drug intoxications like atropine. So patient has low temperature in form of hypothermia, less than 37 degree. Then you should suspect hypoglycemia, shock, alcohol intoxication, and sedative use like clonazepam or alprazolam. If patient has taken in large number, patient can develop hypothermia. If you check respiratory rate, if suppose respiratory rate is more than 16, which is a normal 16 per minute, then you should suspect pneumonia or acidosis. And if the respiratory pattern is abnormal, we will see in the other slides, then you should think of brainstem involvement. If you check for skin, you should check for injuries or bruises, which may help you to lead to the traumatic cause of the diagnosis. If the skin is very dry, then it can be because of diabetic ketoacidosis or atropine overdose. If the skin is moist, wet, then it can be hypoglycemia. So cold, moist skin. If the skin is cherry red, then it may be carbon monoxide poisoning. Needle marks will suggest that patient is having drug addiction, and rashes will tell you that it may be meningococcemia or endocarditis with embolization. How the breath is. If the fruity smell, then you should think of diabetic ketoacidosis. Fetor hepaticus, very bad smell of corpse. It suggests hepatic coma. If uriniferous odor, then you should urine-like odor, then you should think of uremic coma. And alcoholic odor, then it is alcohol intoxication. So this is about general examination. Fundus is also a part of general examination. So if subarachnoid hemorrhage is there, then in retina you can see subhyaloid hemorrhages. Hypertensive encephalopathy may show hemorrhage exudates and arteriovenous crossing changes. You will learn it in the ophthalmology. And in case of raised intracranial pressure, fundus will show papilloedema, swelling of optic disc. Now, neurology. We will move on to neurological reasons. So we have done what are the common causes of coma. How do we take history? How do we do general examination? And clue to each examination point. And now specific neurological examination to reach up to the diagnosis. So first we observe the patient without touching. How is he lying in the bed? How are his limbs? How are his eye? How is his or her eyes? How is his face? Okay. Okay, whether any specific posturing is there or not. So posturing, then we will check for arousable. So first we will try to converse verbally. So આપણે કહીએ કાકા આંખ ખોલો, શું નામ છે તમારું? Or you can directly ask him by name. So if he is opening his eyes spontaneously, then he is fully conscious. Okay, but if he is opening his eyes with your verbal command, then it is drowsy. If with painful stimuli, then it is stupor, and no response, then it is coma. Apart from posturing and decubitus and level of arousing, we will check for the pupillary sign, eye movements, and respiratory patterns. So first is observed without intervention. You are just looking at the patient when he is lying in the bed. So when patient is tossing in bed, okay, he is crossing legs, there is some yawning, swallowing, coughing, and moaning, then it says that it is drowsy state. The second point is posturing. So there are two types of things. One is whether one side of the body is not moving, or that both the limbs are abnormally moving. So this is about both the limbs abnormally moving. Whenever you give some painful stimuli, if patient develops flexion of upper limb along with adduction of the shoulder, flexion of the elbow, and flexion of the fingers and wrist, with extension of the lower limbs internally rotated and plantar flexion, this is known as decorticate rigidity. And whenever you give painful stimuli, if extension of upper limbs, pronation, adduction, and flexion of the fingers, along with extension and adduction of the lower limbs and plantar flexor, this is decerebrate rigidity. Decorticate rigidity shows bilateral damage rostral to the midbrain, and decerebrate rigidity shows damage to the motor tracts in midbrain or below that. Decorticate rigidity has relatively better prognosis as compared to decerebrate rigidity. Decerebrate rigidity means patient may not recover fully and he may die. You should remember this photograph. Okay. The second thing we see is whenever patient has hemiplegia, patient will have lack of movements on one side, okay, or the leg would be outturned. Okay, you can see that right leg is externally rotated, the head and eyes are deviated to the left hemisphere. Okay, sorry, right leg, left leg is externally rotated. Arousal, we already discussed that whenever you ask the patient and he responds, or whenever he opens the eyes spontaneously, it is fully conscious. On verbal stimuli, if patient responds, then it is drowsy. On painful stimuli, then it is stuporous. And no stimuli means no awakening on any stimuli is coma. This is known as brainstem hemispheric posture. You can see the head and eyes are deviated to right side, the same side of the hemiparesis, means there is right-sided hemiparesis. You can see the adducted thumb. The level of consciousness we can see by two ways. One is known as AVPU scale, where we see alertness, B verbal stimuli, P painful stimuli, and unresponsiveness that we already discussed. The second method is we check for the Glasgow Coma Scale. Glasgow Coma Scale, okay, will check three things. Eye response of the patient on your command, verbal response of the patient on your command, and motor response. Okay. Initially, Glasgow Coma Scale was developed for head injury patients, but it has a role in prognosis in a patient with metabolic coma or other comas. So what is eye response? So whenever you ask the patient or whenever you give some stimuli and he spontaneously opens the eyes, it is 4. When he talks to you, when you call him loudly, then it is 3. When you give some painful stimuli and then he opens the eyes, then it is 2. And even though with painful stimuli, if there is no eye opening, then it is 1. In verbal response, if he converses and talk to you fully oriented, then it is 5. If he converses but he is not oriented, then it is 4. He may speak some inappropriate sentences. If words are inappropriate, words are spoken but no full sentences, then it is 3. Only incomprehensible sounds, then it is 2. And if he doesn't talk to you, it doesn't make any noise, then it is 1. And then in motor, if it is obey, 6, localizes to pain, then 5, abnormal flexion, then 4, abnormal extension, then 3, then just flickering of the muscles, then 2, and no response, then it is 1. You can see the minimum will total all eye response plus verbal response from base motor response. You can see the minimum possible GCS is 3 by 15. Glasgow Coma Scale will help us to prognosis. So if GCS is in between 13 to 15 out of 15, then it is mild. So good prognosis. Around 90% of the chance that patient will recover fully. 9 to 12 is moderate. And if the GCS is less than 8, then they are in the coma and the prognosis is bad. Around 80% people will not improve fully. Now we move on to the reflexes. So pupillary reflex means when you throw light in the eyes, the pupil will constrict. Same side pupil also and the opposite side also, which is known as direct light reflex, consensual light reflex. You know, any reflex, there should be some mark. So in pupillary light reflex, the efferent would be second cranial nerve, the center would be midbrain, and the efferent would be third cranial nerve. So when pupillary light reflex is absent, there should be either problem with the second cranial nerve, midbrain, or third cranial nerve. Ocular movements. Okay, third, fourth, and sixth cranial nerve will control ocular movements, and the center of all these cranial nerves are in pons and midbrain. Corneal reflex. So when you touch the cornea with the wisp of cotton, there will be blinking of eyes. Okay. Here, the efferent would be fifth cranial nerve because fifth cranial nerve is sensory component for cornea and conjunctiva. The center would be pons, and seventh cranial nerve would be the efferent, which is motor. Okay, so corneal reflex can be absent when there is a problem with the fifth nerve, pons, or seventh, and respiratory pattern. As a rule, coma due to both hemispheric disease usually preserve brainstem function. So there won't be any damage to the eye or pupils. Now we move on to each heading one by one. So when you check for the pupil, normally people should be equal size and he should react to light. Okay. Most metabolic comas, as we discussed the list, usually will lead to small pupil, but they will respond to the light. So metabolic coma, there won't be any effect on pupillary light reflex. Only the atropine related and cerebral hypoxia related pupil would be dilated. Okay. So around mid-size 2.5 to 5 millimeter size reactive and round pupil usually exclude midbrain damage. Structural lesions are commonly associated with pupillary asymmetry and loss of light reflex. So when midbrain is the problem, pupil would be round, regular, medium size, but they do not react to light. As we know, the center is midbrain. Okay, when third nerve is involved, usually the same side pupil would be dilated, fixed, and not reacting to light, but the opposite pupil would be normal. When the level of lesion is pons, patient will have bilateral pinpoint pupil. They will be reactive. Okay, because second and third cranial nerves are intact, but they will be small. Okay, this is a photographic presentation again. So diencephalic involvement, small and reactive pupil. Third nerve, same side dilated and fixed pupil, not reacting to light, but opposite pupil would be normal. Midbrain, the pupil would be mid position. This is normal position, okay? And they are fixed and they won't do dilatation to the pupillary light reflex. Pons, bilateral small pinpoint pupil, but it will react to light. And pretectal, there will be large fixed pupil. Movements of the eyes. Okay. So position of the eyes at rest. So if patient is comatose, you can open his both the eyes with your hands and try to see where the eyes are seeing. Okay. Second, if there is some spontaneous eye open movements are there or not. Okay. Normally, eyes would not have any deviation or looking to one side. But whenever there is large lesion in the lobes, cerebrum, the pupil will deviate towards the side where there is a large lesion. If there is a large lesion in the brainstem, usually eyes will deviate away from the lesion. So if left-sided brainstem involvement is there, eyes will look towards right side. Okay. Oculocephalic reflex. This all you have learned in physiology. Okay. So you just hold the head, keep the eyes open and try to turn head side by side as well as vertically. And you should check how the eyes are moving. Normally, with changing of head position, eye should not move. It should be fixed at one point. Okay, this is known as normal conjugate iris movement. But if the eyes are fixed, okay, then it is known as absent doll's eye. It's a sign of brainstem damage. This is how you hold. Okay, you are seeing he's holding his head, he's keeping eyes open, and then he's turning his head on the left side towards the right side. Normal person, you can see eyes are not moving, it is fixed. Okay, but in abnormal, you can see when head is turned on the right side, eyes are also looking on the right side. When the head is turned on the left side, the eyes are looking on the left side. This is fixed. This is known as absent doll's eye. Caloric test, we see similar response. We put hot or cold water in the ear and we check how the eyes are moving. Abnormal caloric test means there won't be any response. And the normal caloric test means eye will deviate to the sides of cold water application. Okay. Corneal, we already learned. So this is a single slide which will help you to know where would be the lesion. So pupils, oculomotor and sympathetic fiber, oculocephalic, vestibular, corneal, cuff and gag reflex. So this is one note. Respiratory patterns. You can check how the breathing is happening. Okay. If the breathing is shallow, slow, but regular, then it is usually metabolic or drug-related coma. If the respiration is coming in episodes, so there is suddenly increasing depth and rate, and followed by a phase of apnea where there won't be any breathing, and again the depth would be increasing, the rate would be increasing, then it would decrease gradually, and then again there would be no breathing. Okay, this is known as kind stroke breathing. It can be because of metabolic, diabetic acidosis or uremic coma. Kosumal's breathing, where the breathing would be deep and rapid. This is also known as central neurogenic hypertension, hyperventilation. This happens when there is spontaneous level injury or DKA. Apneustic breathing, where there will be prolonged respiratory gas. So inspiration, pause, expiration, and then there won't be any breathing, which is apnea. And then again, inspiration, pause, expiration, apnea. Apneustic breathing also occurs in case of spontaneous involvement. Ataxic breathing. Suppose the breathing is irregular. Sometimes it is more, the depth would be more, sometimes it is less, sometimes there would be episodes of apnea. There are no breathing occur, medulla. And this usually is the terminal respiratory pattern in many patients when there is severe brain damage, and ultimately patient would die after such breathing. Okay, this is again the same thing. I have shown you the level of lesions. So summary of neurological examination in coma patients. Suppose cerebral lesion is there, pupil would be small, reactive. Sometimes it may look away from the lesion. Abnormal brainstem reflex would be variable, but respiratory pattern would be time stroke. If the midbrain is injured, people would be dilated, fixed, not reacting to light, and Kosuma's breathing would be there. If the pontine lesion, people would be pinpoint, reactive, apneustic or Kosuma's breathing would be there. If the level of lesion would be medullary, pupils would be small and reactive, and ataxic breathing would be there. Gag reflex would be absent. In pontine lesion, corneal reflex would be absent. And if the coma is because of metabolic causes, then the pupil would be small, reactive, and Kienstock breathing would be there. Now we move on to motor function. So first we have done history, then we have done general examination, then we have done specific cranial nerve examination, posture, decipiters, and then now we are moving on to the motor function, alertness, and then now we are moving to the motor function. Okay, so particular attention should be directed when the tone is less. Tone means resting pressure, resting contracted state. What is happening to the plantar response, whether it is extensor or flexor? What is happening to the deep tendon plexus? Okay, and how is patient moving his body? So this we already discussed. If there is no response power, then the grade is 0, and if he is fully responding to the commands, then it is grade 5 power. We should check for the meningeal signs. If suppose unilaterally patient is not moving, when a patient has less movements on one side of the body, right side, and right side is lesser than the left side. If deep tendon reflexes are exaggerated on right side, if plantar is extended on right side and power is less and tone is also less, then it can be a sign of hemiplegia on right side. The cause would be stroke. Okay, comatose patient ho jate to move kare nahi, or history yape nahi. So how do we assess? We give painful stimuli and then look what is happening to each side of the limbs. One side of the limb he is moving, but other side he is no moving. There is no movement. Then the cause can be stroke. You should subject the patient for imaging. You learned this in anatomy. How would we look for the meningeal signs? So we should check and physiology. So neck rigidity. We should try to flex the neck. He will not be able to flex. Then it is known as neck rigidity. And bruising key sign is whenever you flex the neck, there will be flexion of the limbs. This is because of the irritation of the meningeal covering of the spinal cord. And Kernick sign, whenever you semiflex hip, semiflex knee, and then try to extend the knee, full extension won't be possible. There will be pain here beneath the thigh because of irritation of meninges. These are the signs of meningeal irritation. So if any patient who is comatose and these signs are present, along with the history of fever, ultrasensorium, conversions, you should think of infection, intracranial infection in form of meningitis or encephalitis. This is one of the most important unresponsiveness. We have seen such patients also, okay, which is known as psychogenic unresponsiveness. So because of the psychological causes like depression or anxiety, patient will behave as if they are unconscious, but in reality, there won't be any structural brain lesion. Why it is important? Because Here, the treatment would be counseling and antipsychotic medications, antidepressants, rather than over investigation. Okay, until you counsel, until you remove the factor which is causing anxiety, patient will not improve. Mind, these people are not malingering. They are not consciously behaving abnormally. They have some psychological problem, and that's why subconsciously they are behaving as if they are having coma. Okay. So what are the key indicators that will help you, okay, to differentiate between psychogenic coma and organic coma? So in psychogenic coma, patient eyelids would be tightly closed. So જેટલું તમે આંખ ખોલવાનો પ્રયત્ન કરો ને, patient વધારે ને વધારે tightly આંખ બંધ કરે. Second, તમે જ્યારે પણ કેલરિક ટેસ્ટ પરફોર્મ કરો, કોલ્ડ વોટર કાનમાં નાખો તો આંખ એ તરફ જોશે. There would be nystagmus. Nystagmus હશે મતલબ brainstem functions are intact. So this is not a deep organic coma. And if you perform EEG, electroencephalography, it will be normal. So these are the three things which will indicate that patient might have psychogenic unresponsiveness. Prognosis of coma. In general, coma carries a serious prognosis. Okay, it largely dependent on underlying cause. If coma is because of depressant drugs, the prognosis would be good. The moment the effect of the drugs wanes off, patient will become normal. Usually, metabolic causes like hypoglycemia, hyponatremia, hypernatremia, they will have better prognosis as compared to structural lesions like stroke or tumor or injury. Length of the coma means and more increasing age would have poor prognosis. જેટલું જલ્દી કોમા ઇમ્પ્રૂવ થઈ જાય એટલું પેશન્ટને સારું. અને early involvement of pupillary reflex, corneal conjunctival reflex, gag reflex, brainstem reflexes, then it is a bad outcome. How do we manage? This is the last slide of today's presentation. So whenever any unconscious patient comes to us with a history of trauma or something, we stabilize his neck, we secure his airway with the help of intubation if needed, oxygenation, IV line. We check for sugar. If it is hypoglycemia, then we just give sugar and patient will become normal, and thiamine. If there is no regaining of consciousness, then we take proper history along with detailed examination. Okay, and we check for pupillary response, oculomotor response, positioning, motor pattern, breathing pattern, reflexes, smell, ultimately, and then we pull the samples for some investigations, including electrolytes, kidney function, liver function, arterial blood gas analysis for hypoxia and acidosis, and toxicology screen to look for the poisoning, along with Lyle's tube lavage. If we do not find any cause or etiology, then we go for the imaging, preferably MRI, but if patient is not stable, then we can go for CT scan. Okay, if we suspect hypoglycemia, we give sugar, thiamine. If we suspect seizure or history of seizure, then we give lorazepam with anti-epileptic drug. Naloxone can be given for opioid overdose, and benzodiazepine overdose, we give flumazenil. If there is no cause we found, gastric lavage should be done in case of poisoning. And then we should shift the patient to ICU and wait for the reports. If nothing can be found out, then we can perform EEG and lumbar puncture. Okay, there is one entity called non-convulsive status epilepticus, where intracranially electrical activity would be more. So seizures would be going on, but patient would not express any movement on body. એટલે તમને જોઈને એવું ખબર ના પડે કે પેશન્ટને ખેંચ આવે છે. પેશન્ટ સુતા જ હોય, હાથ પગ સ્ટેબલ હોય, સ્ટેડી હોય, પણ બ્રેઇનમાં ઇલેક્ટ્રિકલ ડિસ્ચાર્જીસ ચાલતા હોય. એને કહેવાય નોન કન્વલ્સિવ સ્ટેટસ એપિલેપ્ટિકસ. અને એમાં આપણે એન્ટી એપિલેપ્ટિક આપીએ ને તો પેશન્ટ કોન્શિયસ થઈ જાય. So in this entity, EEG will help us. So thank you for listening. The exam questions would be approach to a patient with coma, enumerate various causes of coma, and what is GCS. That's how they can be asking. So thank you very much to all of you. Please take care and stay safe. Bye.